I'm the facility educator over at Banner Gateway, and y'all know Erica.
Good morning.
She does a lot of the MDA, but we both kind of help each other out here quite a bit. So what we're going to talk about today is your alternate airway when your patients come in. And then I'm going to have you guys, I'm going to give you a scenario. I'm going to have you come up and tell me how you're going to ventilate this patient, okay? Because we're going to go through the situation. We're going to teach how to suction a trach. The other one is if the trach pops out, which happens, and it's a common tale. And the other thing, if you have a patient with a laryngectomy, but they've got a trach tube in, where do you ventilate? And vice versa. So I'm going to cover all three of the different altered airways that we deal with here on this campus, okay? Because we see a lot of head and neck here because of just who we are. And we do a lot of head and neck over at Banner Gateway, okay? So a couple things we're going to deal with here is, if you guys just want to pop up here a little bit closer here, is I'm going to have you touch it, do whatever you want with it, okay? So we have three airways that we deal with here at Banner Gateway. One is a laryngectomy, and remember the larynx is below the above the trachea, okay? So you have the larynx up here, then you have the trachea down here, and then it goes into the bronchus, and then the right main, and then the left bronchi. So the other one that we have is like I said, a tracheostomy. The other one is a laryngectomy, and the other one is a partial laryngectomy. And I'm going to cover all three of them. All right. So you have a patient that comes in with the tracheostomy. Most often they're going to come in with these. Is that correct? When you see your patients, they're going to come with these. Usually over at Gateway, they're sutured, but when they come over here, by that time, they're going to have these trach ties in right here. Okay. One thing that you guys need to do is to discover what type of an airway you're dealing with. Obviously, if they're using a Larry speak when they're talking like this, then you know it's a laryngectomy because they're using their Larry speak, or they do that esophageal speaking, okay? So you know they've got a laryngectomy, but they may come in with still a temporary trach, okay? Or they'll come in with just a laryngectomy and they have their stoma, but they're not putting their Larry tube in. And a lot of times when I see patients that come in with Larry tubes, I'll ask them in the hospital, I need you to bring your Larry tube. Where is it? Well, they'll usually tell you it's in the trunk of the car.
What do you call it, a Larry tube?
A laryngectomy tube. It's just a small, little, tiny curved tube.
Oh, that thing that they slip in there.
Yeah.
Okay.
And it helps keep that stoma stable. And I always like to have them in because if I ever need to use it to ventilate them, it just provides more stability. But they don't always wear them. So don't always. I've even seen them down here over here on the first floor when they're volunteers, they're walking around without their Larry tubes in. But it's an established hole. It's much like our pier stairs. You don't always have to wear an earring in it. It's not going to close up on you because it's all scarred in. So you don't always need it in. But then the other one is your partial laryngectomy, which a lot of times they're going to have a trach tube in. Okay, so don't look at this and assume it's a tracheostomy because it could be a laryngectomy with a temporary trach. And I know Dr. Tomei here will a lot of times when he does his laryngectomy, he'll put a temporary trach in and they even go home with it and they may pop back in too. So you may see them here too. So let's start with our first altered airway. So we have a tracheostomy tube in, but you have a patient here and this maybe pops off right here. Now your trach tube comes out. What are you going to do? Your tracheostomy tube comes out. What are you going to do? And you don't have to panic. That's one thing I don't want you to do is to panic, okay?
Because they got a hole there.
What do you want to do? I have some things here that I want you to look at. What do you think you need here?
An arbitrator, if they're inpatient.
Thank you for that. Okay, so I need my obturator. So you can give me this trach tube here because I think this one's a different size, okay? What else am I going to do?
Make sure assess their breathing. Okay.
Okay.
See if there's something obstructing. I would probably clean it, would be my instinct to clean it.
Okay. Anybody else? So we got our obturator. So the one thing you want to do is get a 4x4. You can cover it here. Okay, you want to cover it here. Then you can ventilate them here. Okay, so we just have a regular tracheostomy tube. The larynx is intact. It falls out. just cover with the 4x4 and ventilate them here. That's all you need to do. Okay, then you're gonna ventilate them here. Then adult ambu bag and an adult mask. Does that make sense?
This is only if they're not breathing.
You still pretty much wanna do it anyway, so just cover it here. Okay, you can ventilate them. Okay, but watch their sats too. They may not always need it. They might be okay. If it's an established trach and it's been there, say, a year or two, which sometimes they do, especially if they've had their larynx worked on, then you can still ventilate them here. If I have a patient who needs to be ventilated on their stoma, and let's say, for instance, maybe they've got a lot of stuff up into here, it's hard to ventilate them up here, I can still ventilate them in the stoma, but how am I going to do that? Thank you. Yep, so, and I don't have a pediatric mask, so if I were to use this on me, do you see how, I'm not gonna get it, I don't care if you even put my head all the way back, you're not gonna get a good seal. That's why we have to use a pediatric mask. So, I don't have one here, we only have a couple at Gateway, and then I'm gonna ventilate them here.
So if we don't have a pediatric one, since we don't know peds over here, what do we use?
You always have to use the peds one here.
I took your,
It used to be that all the ambu bags had both in there. I
They
don't-
used to. What's
I don't
over
know that
there?
That's true anymore.
Yeah, I think they took those out.
Okay.
So I think we need to get one over here, even though, but you need, because you have to get a pediatric one. You can't use an adult. I mean, if you try to use an adult on me, there's just no way you're gonna get that, a good seal. So you gotta have a pediatric.
In
So,
our patient that we're treating here then, would that be the case? Cause he's completely swollen,
Yeah.
like,
in that event, if this trach comes out and he's completely swollen, it's gonna be hard to ventilate, then you're gonna have to go to the stoma.
Okay.
Go to the stoma, okay? Because you could do either or. It's sometimes just preference. If it's a real fresh trach, and then we deal with those over here at Gateway, the tendency is they wanna close up. But after they've been established 7-10 days, and you're starting to build up scar and it's gonna stay open longer, you can ventilate. But you can ventilate either or, but if it's a real fresh trach, which isn't what you all are dealing with over here, this stoma is pretty well established, so you can certainly use that if they are swollen up here, which is sometimes the case with oral cancers and things like that. So the first thing you wanna do is just cover with a 4x4 and you can ventilate here. In the event you're not able to really ventilate well up here, you still have your stoma. But you gotta use a pediatric mask, so y'all need to get one. Okay, so it'll be one of your top priorities to do that. Because if you have SWAT who will do it for you, they're gonna ask for a pediatric mask. Does that make sense? Is that clear as mud? Okay, so now we have that one there with that trach that has fallen out. But if I decide now, here at Gateway, per the policy, and I'm gonna let y'all read the policy later on if you want, but the policy is here at Gateway, which is a little different from the other facilities around Banner. Nurses can reinsert these trachs, but you have to be validated. And there's no nurses that are really validated to do this. Even Restford, the only one that does it is the physicians over at Gateway. Not all of them will do it either. But I'm pretty much the only one that'll come in and reinsert them if they need to be redone. So, and SWAT, I'm getting them trained up to put these in. So you have to have an obturator, okay? And a lot of times I'll hear nurses say, I'll ask them, what's the purpose of an obturator? And they'll say, oh, it's to hold the airway, put it in the airway. That's not the purpose. The purpose of it is kind of like, to me, a guide wire. You put it here, and then you need to, I'll come in and reinsert it. Okay, it's not that hard, but the only problem with reinserting these things, you have to be careful because there's this little thing called the pretracheal space, and when you reintubate with there, you can put it in, it goes pretracheal. So the lungs won't expand, you'll get sub-Q air, your SATs won't rise, etc. So you have to be real careful. But you have to have an obturator. And I always, sometimes patients will come in, they may not have their obturator in. So you'll just have to call respiratory and get an obturator that will fit this size of trach. Or not one size fits all. They actually fit the size of the trach that the patient has in. And Banner's policy at Gateway is they must have one trach available at all times that is one size smaller than what's in their throat. Okay? So that's our policy here. At the rest of the Banners, they have to have a size that's in currently, but at Gateway, our policy here has to be one size smaller. And then if you look at the policy, it speaks to it real clearly. Okay, any questions on that one? Is that clear as mud? Yeah, no?
Yeah, it's clear.
Okay, okay, so let me put this trach back in him, here. Okay. Put my ties back in. So what am I gonna do if my trach falls out?
Ventilate.
Where am I
Cover
gonna
the-
ventilate?
Cover the stoma, ventilate the mouth if you can,
Okay,
if not, ventilate
and what if
the
it's
stoma.
difficult to ventilate the upper airway, face and mouth?
Then ventilate the stoma with a pediatric.
And you want an adult ambu bag, cause you need the full tidal volumes. You don't wanna do a pediatric mask, you want full tidal volumes. Okay, very good. So we'll come back to that later on too. The one thing I wanna show y'all is these Aleve dressings. I know you don't have them over here, but these are the greatest things.
We actually do have some.
You do.
Not the
Not
trach
those.
ones, no.
Oh, you're talking about like the regular Aleve?
Yeah.
Yeah.
These are Aleve Classics, these are pre-cut. The nice thing about these is you can cut these, you won't get shards like you do with these 4x4s here. So if you cut them, you get those and they can get in the trachs. Yeah, so you can cut them, you can manipulate them. The nice amount, they can stay on for 7 days, mildly absorptive, and they fit beautifully, and they also prevent the breakdown that we see with trachs.
They seem thick. We have drain sponges that already come cut, so
Yeah.
they're clean, you know, the clean gauze, you don't
And
have
the
the
problem
strain.
with those is that
This seems thick though
no,
under
it's
here.
not. It's not
Okay.
at all. And we use them all the time at Gateway, and
Okay.
they've really decreased our pressure ulcer rate. These things are
Uh-huh.
amazing. We use them on the peg tubes too, because
Uh-huh.
they're bolsters, they're great
Yeah.
bolsters, and they prevent that excoriation underneath there.
Cool.
But the nice thing I like about these is they might seem, but they're just incredibly pliable, and they just mold to everything.
I just know Dr. Schellenberger, because a patient that comes right now, his trach was super tight.
Yep, and these are
And-
still sutured?
I don't think this was sutured, no.
Okay.
But honestly, he's done treatment and it was real awful around here.
Yeah.
And the family said, well, doctor said we can't, loosen this up. It needs to stay
Yeah.
super tight.
Tight.
And I couldn't even get a, flat gauze under there, a drain sponge.
Oh my gosh. And so unfortunately, they'll probably break down, and that's what we're seeing at
Yeah.
Gateway a lot, and that
Okay.
becomes on us now.
Yes, right.
That becomes a fallout on us, and
Right.
so, yeah, I talked to Dr. Schallenberger about it, and, so we went with
Okay.
these things here, so you may wanna just talk to him and say, I'd like to really put this Aleve underneath there.
Mhm.
These can stay on for 7 days,
Mhm.
they're mildly absorptive, whereas the gauze sponges, or the ones that are pre-cut, they used to be called soft wicks, they retain moisture.
Mhm.
These do not.
Keep the moisture next to the skin.
They keep it, right, and then it does, and so with this, you just wipe off the moisture off this here, cause they're just very mildly absorptive.
Mhm.
So we've had tremendous success with these, and these are also good for peg tubes, so if your patient's coming in a pain, it's all red, just say, hey, these are perfect for that, and they can order, Leave-In Classics, and,
Tracheostomy.
yeah, they can order them from Amazon, so they can order a box or
Patients
something.
can order them too. Oh,
Yeah, they can,
cool. That's good to know.
you can order all the stuff from Amazon anymore.
That's what I hear.
Or Amazon's great. Okay, so any questions about trachs? So I'm gonna have you go through this again, I'm gonna give you, Kate, you're gonna go through, you're gonna take care of this for me, okay? So now we have a laryngectomy as your other alternate airway that we do here, but they may come in with a trach, because it's a pretty fresh Larry, okay? So if my tube were to fall out, and I've got a laryngectomy, where am I gonna ventilate? I've got a laryngectomy with a temporary trach in, but my trach fell out. They're over here, you're recovering them, and your trach falls out. What are you gonna do? But they're a laryngectomy.
Don't you have to ventilate stoma then?
Absolutely. Would you ventilate up here? Is that an option? No, the larynx
Come
comes
out there.
They'll come out the mouth. But you'd be surprised how many people would do that. And it's been done a lot. So that's why we have this alternate airway initiative at Banner, because of that. It's just not here, it's
And if you're
nationwide.
walking up on a patient that you don't know, you don't always know which.
You don't. So it's just best to do than to ventilate the stoma, if you have no clue, but here in the hospital, you should know. Now, if you're out on a field, obviously you're not gonna run around with an ambu bag and everything else, but in here, you should always know. There's no reason you should never know what your type of an airway you're dealing with. Read the chart, ask the family, etc. Or talk to the physician, okay? So, I'm gonna ventilate here. Why? Because I don't have an upper airway. It's gone. My larynx is completely gone. And of course, they can't talk to you because their vocal cords are in their larynx. Okay? But you should always know what kind of an airway you're dealing with here. That's why we call this Altered Airway Initiative real big here at Banner. Okay? So, now let's say my third altered airway. I have a partial laryngectomy. And they'll do that because maybe there's strictures, maybe cancer they've had to remove, but my larynx is still intact, but I've got a partial laryngectomy. But my trach falls out. What am I gonna do? Where can I ventilate? It's a partial laryngectomy. You're recovering this patient. They have a trach tube in, but my trach falls out and they're a partial laryngectomy.
I guess my question is, if you still have to do if you're saying partial, then what's removed?
Partial Larry,
Just
part of the larynx.
The larynx, but
So they still are
partial.
able, so
but
you
they
could
still have an airway then?
They do.
Yes, so you
Okay,
can- then you
that's
can-
where I'm trying to get to.
Good. Absolutely right. So you can do both, here or hit the stomach. If it's a real fresh Larry, which is what you all are fresh partial, and it's a fresh trach, usually it's not a problem for you guys. You can ventilate either place.
While we're talking about the trach falling out, if that were to happen, and since none of us are validated, who would be our go-to people over here?
Will you call SWAT?
SWAT?
You want to
They've
call
all been
SWAT?
validated or?
Nope, they have not. And actually, there's very few people have been validated to do it. But the only one that can do it are the physicians, a few of the physicians at Gateway and myself.
So I don't wanna reach out to a physician or just have SWAT
No, you wanna
manage it?
reach out to your physician here, call SWAT,
SWAT,
reach out
okay.
to the physicians.
Okay.
Yep, and some of these guys here should be able to do it. I mean, they learn that stuff in med school too. So, they should be able to put the
In
thing
Radom?
back in.
Our doctors in Radom?
Absolutely, they all go to med school. So they should learn how to do all that stuff. And they may not feel comfortable in that event, then they reach out to SWAT and sometimes.
I'll call Schellenberger's clinic.
Yeah, if they have Dr. Schellenberger or Tomei or what was that, come and put your trach back in. So, but you're welcome to reach out to me, I'll pop over and put it back in for you. But yeah, it's, but remember, what do I have to have at the bedside though?
Yeah.
My obturator. I have to have an obturator. Because if I come over, the physician comes over, the first thing they're gonna ask for is an obturator.
So if the patient is a fresh trach, are they supposed to have their obturator with them?
Yes.
Yeah,
Okay.
and various sizes too, I guess.
I remember this came up with that.
When Erica put that together,
Put
yeah,
together.
yeah.
And it was told to us then that the only people that could replace a trach was the physician.
Now, if you're a validated nurse, so if you read your policy here at Gateway, Banner, system policy, but it drills down to Gateway, nurses can do it, but they have to be validated.
Okay.
Yeah, they have to be
Fortunately, it's not
validated.
come up.
Yeah, and it's, by the time they make it to y'all over here, they're days post-op anyway, so it's usually not a problem. It's only more Gateway when it's fresh,
It's a fresh one.
and usually they're sutured in. And
I remember as an inpatient nurse, that was always taped to the head.
it was.
Of the bed, but, I mean, our people are obviously not
I know.
in that situation
In
anymore.
that event, first of all, if you call me, I would come over, and the first thing I'll say, do they have an obturator? Well, we don't see one. I'm gonna ask them what size trach do they have, and I'll grab one and pop over. Yeah, and then I'll just give it to the patient, tell them they have to keep it with them at all times. Because you have to have an obturator, put that thing
So what
back in.
sizes are there?
You have 6, 7, 7.5, 8 trachs, so you have different sizes on trachs. So,
We don't have any.
Are they part of the trach kit?
We have our
they are. They come
So
in
you
with
could
the
just
trach-
grab the trach and the obturators in it.
With your
That's what I
trach
thought,
kits.
yeah.
They're with, yeah.
Yeah, so, and I can usually go to respiratory and grab one. But usually by the time these patients are gonna make it to you, they've got their established trach, they're usually gonna be pretty stable. I mean, it's not like over there where they're gonna, oh, we gotta get them ventilated. Here, it's like, they're gonna be pretty much stable.
Yeah.
But hey, stable is relative, right? When you're dealing in hospitals or anything like that. Okay, so any questions between partial laryngectomies, and trachs? Okay, so I have a patient that has a laryngectomy. I need you to come up. This trach has fallen out. I have a laryngectomy and my trach's out. What are you gonna do? You're the nurse.
Assess their respiratory status, ask them.
Well, they can't probably talk, but we're gonna ventilate, down here with a pediatric.
Okay, I just don't quite know. That's a pediatric mask. I don't
Okay.
have one. We have
And then I
one.
would have somebody call about having it reinserted.
Okay. And who would you call first, though?
Who would I call first for that? I might, SWAT.
And send somebody to get our doctor.
Yeah, and you wanna notify that physician and see if they'll come in and put it back in.
So SWAT would be the first one to call,
Yeah, call SWAT.
Okay.
Yep.
and they're certified. to
Not
do
all of
this.
them are certified, but none of those guys are certified at this point. We did have a couple that were, and actually I think Deb Dompier was certified, but I don't know if she'll put it back in or not. And you put them in so infrequently, I think the nurses get it's so infrequent, and you're like, oh no, even some of the physicians over at Gateway won't put them in, because they just don't feel comfortable. Can't even get anesthesia, put them back in. They don't feel
So
comfortable.
we don't do the patient any service though, like elevating their head or any of that in this scenario.
Just leave them.
We get a
they're
sat,
fine.
just put a sat, O2 sat on them so we can monitor that.
Absolutely. Okay, so, and then one of us will come in and re-put back in the trach too, okay?
Okay.
All right, so, go ahead. I have another patient who has a tracheostomy and upper airway's intact, the larynx is intact. I'm gonna leave that off. So my patient has just a tracheostomy, larynx is intact, it falls out. I need you to take care of this patient for me.
Okay, I'm gonna call SWAT.
I'm going to airway here, but I'm gonna cover this,
Okay, what are you gonna cover it with?
a gauze.
Right.
Or-
And then ventilate them
And
there.
then, uh-huh.
Is it an option to ventilate them here?
No, cause it'll,
It doesn't matter either way,
You can
but I
go low,
usually go
you can
straight
push-
to the top.
okay, you can cover that, okay.
But if they're all swollen and back here, cause sometimes after radiation and things like that, they may be swollen, and you can always go to the, that's the beauty about a trach. You can do upper or stoma or upper.
Yeah, what brought this to our attention is we do have a guy that his tongue is out. It almost covers his face. And he
Oh my
constantly, yeah, it's a very
Really?
sad, terrible case. And, when he goes to lay on the table, he, panics because he needs to be suctioned. We attempted to suction here, but there's really nothing. It's still here. So we gave him the,
Yonker
we gave him
or
the
a-
Yonker, but the Yonker is pretty big, and he kind of hurt
Yeah.
himself a little bit, I think, trying to, get around that, so.
So he wouldn't
So
be,
he
and
isn't really,
he's trained?
yes, oh, yes.
That's the one she's talking about that was so
And I-
tight.
Oh, that guy.
Oh, well, actually, it was another guy.
Oh, it was?
that-
Oh, I'm
but
sorry.
Yeah, that's okay, yeah.
But when we got there, the patient was sitting up,
Mhm.
and we were being told by therapy that when they laid him down, he couldn't maintain
Yeah,
his
with
airway,
him-
so that's why.
So they
Yeah,
call
with
my
him,
call
we
was
can't
his
say
just-
trach
this.
needs to be suctioned, but when you go and assess him, it's usually here.
Here.
And he will tell you when it's good to go.
Yeah.
But we did attempt to do it here, also, just to make sure there was nothing.
Yeah, so in that event, it wouldn't be optimal to, although you can do both, it wouldn't be optimal to go up here. You just wanna go down to his stoma.
Yes.
It says, it really appears that he's
more
mouth
droll.
breathing, that he's mouth breathing. Even, he is trached, and I understand why they trached him, but he appears to be mouth breathing when you watch him.
Yeah, probably, yeah. It's just a natural, I think, reflex that people wanna do that. But for him, you'd wanna ventilate down here, which is perfectly okay. Cause remember, with a trach, you can do here or here.
Yeah.
A partial laryngectomy, you can do here or here. But with a laryngectomy, it's gotta be here. So I have a patient with a partial laryngectomy. I have a patient with a partial Larry. And I have a trach tube in that falls out. What am I gonna do? Pop on up. Sorry, that's okay.
I'm going to, call SWAT. It's partial, you said?
Partial laryngectomy.
So call SWAT, and I'm going to, I could ventilate either place. And
Yes, I do, just wait,
That's
and
it,
then
yeah,
get someone
wait for
else in
someone
here
to come.
re-put the tube back in, okay?
Mhm.
So, so those are the 3 alternate airways we deal with here at Gateway. Very common. I mean, like I said, when I come in here and I see some of your volunteers running around with Larry and San, I know what's going on with them because obviously they're head and neck patients. But we see a lot over here because we're in the Anderson and they bleed over from here to back and forth. So those are the 3 alternate airways that we deal with here. Any questions? So what do I need at the bedside at all times with a trach? Obturator. What's the purpose of my obturator?
Get back in.
Very good. Okay, so now you know more than probably a lot more than nurses know, because most nurses you talk about these things is they think you put them in a stone and keep it open. It's not what the purpose of that is.
Suctioning?
Suctioning. The other thing real quick here, make sure that you keep the, and we'll go talk this, we talk about cleaning the trach. Make sure that you clean these little crumbs, I call them crumbs, they're like scabs or things that have built up. Keep them cleaned off from that trach because they'll slip into the trach. They can slip into the trach. So you want to keep those cleaned up. Okay? So, suctioning. When you suction your patient here, we have in clinical skills is really clear about suctioning patients step by step by step, so you should just follow it sometime. Make sure you have your suction here. You don't want it to go past 150 millimeters of mercury. It's too much pressure on the lungs, okay? So, I always like to wear a face mask with a shield because if you take, say they have a trach collar on them, which I don't know, you always use trach collars over here on your patients when they come out of procedures or anything? They might have a trach collar. Do you use any oxygen on them at all? They're okay. So, but let's say for instance so we don't, but they're coughing and all of a sudden some little piece of sputum will pop out of there. And it's happened before, you know, getting your hair sometimes or something of that type. So I usually like to wear a mask with the shield up here to protect my eyes. But it's your call. You don't have to, but I like to do that, okay? So I've got it set at 150. I usually like to keep their head up at about 30 degrees when I'm suctioning them. Okay, so you're gonna open this up and this is sterile, all right? So I'm going to take one of my gloves here, and these are vinyls, which is perfect for me because I am allergic to latex gloves. And you can suction them as often as you want. There isn't any policy that reads that you can only suction them so X number of times. You can suction them anytime you want. So you have your suction catheter. It doesn't need to be lubricated. Do not lubricate it. I've seen people do that before. You also have in here this little, put sterile saline in there so you can clean out your tubing here. Okay, I don't have saline, but so anyway, I'm gonna leave it right here. This on here. So I'm at, and I usually like to wrap it around here just a few seconds because if I don't, and for purposes of this, I'll break sterility on this here. Because what I've had happen before, if I don't do that, I'm doing this and I'm touching my arm or something like that. Okay, so I'll just do it like this just to kind of hold it a little bit more stable here. So then, if I have a patient who's on a trach collar, which obviously y'all don't use here, so I'll put some sort of I can ambu them, give them 100% oxygen, okay? Or if they have a little trach collar with some oxygen, I'll just leave it on them to give them a few O's. But when I talked to a patient one time, I asked him, I said, tell me what it's like when I suction you. And he says to me, you ever felt, he goes, it's like a vacuum cleaner in your lungs. And it's just pulling, he goes, there's no way you can take a breath because you're sucking everything out of me, okay? So if you're going to, you'll need to ambu this trach here, suction, or give them about 100% of a few deep breaths here. Then you want to go down. And again, what is the max I can have this at? 150, okay? So I'm going to go in. Do not apply suction while you enter. Leave the fingers off the suction. You want to gently insert and don't be too aggressive. Now I've hit resistance. You don't want to keep shoving in, okay? Once you hit resistance, that's it. Pull it a smidgen back. Then I'm going to suction, and you can circle a little bit here and suction, and then bring it out. 15 seconds maximum. Because otherwise you're gonna desat them too much. Okay, so I'm gonna amble them with 100%, couple of breaths. I'm gonna go in gently. I feel my resistance come back a smidgen, put my finger on the suction, bring it up, slowly circle, come up, no more than what? 15 seconds, and then I can bring this over, and you kind of want to hold this over here and give them a little bit of oxygen, because they're going to have air hunger. They're literally going to use to suction all their air out. Okay.
Just so you know, here we don't do that.
That's what I was gonna ask,
No.
okay.
You guys aren't ambling here
Mm-mm.
whatsoever. You just suction them out.
Mhm, mhm.
Or do you monitor their sats?
Because
Don't you?
they're, these people are pretty well established trachs. I mean,
Okay.
they're caring for these at home and they're good.
Okay.
Sometimes it's the position when we get the mask and we lay them down that they, they get a secretion built
Okay.
up. And so we just come in and suction it. Usually only takes 1 or 2 times and
times.
they're good to go.
Yeah.
But we don't ambu.
You don't ambu?
Before. and
Okay.
after, no.
Well, then that's whatever your policy or whatever y'all do over here, then
Yeah.
do that. But let's say, for instance, I'm getting ready to suction this patient, but there's a bunch of stuff right up here in the very front. Do I still want to continue going down? No. Usually you want to go in just enough just to get all that, bring it out. Let them get their wind back, and then you want to go back in. Maybe do a little bit more deeper suctioning on the patient. Okay?
I have a
Questions?
funny little story. Well, it's not funny, but my husband had head and neck cancer in 90, he got his trach in 97. And so I got everything at home, and as he was progressing, I was told one time too that you can never suction too much. And I mean, I took that literally.
Really?
And I was suctioning him, and the hospice nurse came out and she said, I have got to tell you, I've never heard more clear lungs in a person that was this close to passing away. She said, wow. Yeah. Oh yeah, I took it very, did not want him to
Yeah.
be uncomfortable and not, tell me or.
How long
yeah.
did he have his trach in?
I'd say, not quite a year.
Yeah.
Not
Did he
quite.
have did he just had the head and neck, did he have a partial Larry, or do you know?
No, he didn't have any
Nothing
issues
on
there.
that area. Yeah.
His,
He just had a lot of swelling.
correct.
Yeah. Yeah, that's what happens. That's why they do that. It's similar to that actor Val Kilmer.
Uh-huh, right.
Yeah, he has a tremendous still of swelling. I think
Yeah.
they even worked on his larynx a little bit too,
Mhm.
so. So anyway, any questions on the suctioning? What's the max I can put this at?
150.
Okay, and how long do I stay in?
15 seconds.
And do I apply suction as I'm entering the tray?
No.
Okay, very good.
Who's going to be our brave,
Sold to pop up here and do this.
somebody that's not familiar with it?
Yes, I think one of
Come on
those-
over.
Go to the other side so I can video you.
Somebody's here.
I won't. I'm totally focusing on Larry's neck.
So am I just doing the section
So that
part, or
means-
should I start the whole
Yeah,
sterile?
You know, here, do this one right here, because I've got several of those here. Take this one back from you, okay?
Actually, right, yes.
So I can get the section set up before I even do this,
Yeah,
right?
do
I can
everything
start
before.
this. Okay.
I think they do.
Go ahead and turn it on. Make it real life. Real life.
Everything before.
Okay, so no more than 150.
That'd be great to have some.
On that little sheet you sent me, I thought it says like 120 was optimal, is that right?
150.
Okay.
So if you've watched clinical skills, it's fit 150 or less.
Okay.
But you don't want to go too low, because then you're not going to be able to suction. I'd say about 150 is where you want to be.
That's me. Every time we go back in these procedures, that happens to me.
Yeah, every time.
Then you can have someone pour some saline in there for you, so you can
don't apply suction. Put it, insert till I meet resistance.
Correct. And this one's gonna be real shallow, only because it's not buried. It's just,
Oh.
you feel it?
And then come out.
Just
an
pull it
inch.
back a smidgen,
Okay.
and then,
And then do suction and swirl it out.
for how long?
No more than 15 seconds.
Yeah. Almost safe. Okay?
And I would just clear the line with saline and
Mm-hmm.
again. Okay.
Go again, how many times they need it. Okay? Anyone else?
Christine, you want to be brave?
I'm fine, I get it.
Okay.
Thank you though.
Anybody else want to?
Any others?
Did it a few days ago.
You're a pro at it, because your husband.
Well, I'm not a pro, but I do like to hear it nice and clean.
So his trade is out now and.
He's passed away.
Oh, I'm sorry. I'm real sorry. So, very good. So those are our altered airways, what you're going to deal with here, and then we just need to get the pediatric mask in there.
Yes.
Because you definitely need that.
I'm glad-
In the event that your
yeah,
patient
I'm-
codes or
I'm
not
absolutely
just
glad we
codes,
did
but
this.
something happens,
For that.
because then it's there, so Erica can.
Because I'm gonna tell you, I was under the delusion that these things had both in here.
They used to. When I first got to Gateway, we used to, but I think they're out the system. It's just the ambu with the adults.
So that's
Yeah.
disturbing. I would not have known that.
Yeah.
That's why we do these things. So, but anyway, but y'all might want to just start looking at these leads.
Yeah.
Yeah.
Order
These
some.
things are
I'll order some of those.
amazing, and we can't keep them in stock at Gateway anymore. They're kind of special order. If you want them, you call supply chain, they've got the number. And they know it well, because I'm always down there talking to them about these things.
Because we do end up in that situation where we're trying to clean stuff up.
Or if you have a patient that pops through and they have a peg tube in,
Yeah.
clean
We
it
do a
underneath.
lot, we have a lot of that too.
Those are amazing for those things. And
Good for
I found
those.
it, yeah, so I got called over to the infusion center once by clinical nutrition. They said, Lord, we've got this peg tube that's draining everywhere. And I'm like, well, maybe the balloon's not inflated. It needs to be. So she says, no, it's inflated. So I popped over, it was just all excoriated. It was looking pretty bad. We cleaned it on underneath there. So we put this underneath there, and it provided a bolster. So it kind of pulled it out a little bit more, and also to help out with excoriation, and it stopped leaking. These things are amazing.
I bet they're
And the
comfortable.
colors
Yeah.
are.
Much comfortable, and like I said, yeah, the company says up here tells you exactly the use, one-time use, obviously. They're sterile, but they don't need to be because this isn't sterile, the trays aren't sterile. But the other thing is they can stay in for 7 days, mildly absorptive.
And the color side goes up?
Huh?
Color side goes up,
Yes,
right?
color side goes up, yeah. But remember, now trach, we're going over trach cleaning here?
Yeah.
Yeah.
Trach care, just if you have to do the
Let's
cleaning.
Trach care here real quick. The one thing here at Banner Gateway, it's both nurse and respiratory that takes ownership of the trach. In the other facilities, a lot of times, it's respiratory, and some other facilities, it's nursing. So it's pretty well spelled out in the policy, but at Gateway, it's a shared responsibility twice a day. Has to be done, or more frequently if it's soiled. Remember, you wanna keep those crusts out of there, because they could flip over into there, and then they can get pneumonia. And then you've got a lot of other problems. Do we ever use peroxide anymore? No, peroxide is not used. We wanna use regular, saline. Absolutely. So, same thing, you're gonna have a couple of gloves here. Okay, you want your saline out. And I always have someone put saline in for me. Do y'all ever clean trachs much? Do you clean them?
Not too much.
Not really. Yeah, the important thing is they have to stay clean because of the crust that build up, and the other thing is you're gonna deal with is, you know, the inner cannula can get pretty messy, and that can get messy. So you have a bunch of 4x4s, you have your pipe cleaners, etc. And then you also have your, and I usually like to put this on here. Nurses don't, you know, it's not, either or Banner doesn't really speak to it. The uses, I like it, to put here, right like that, only because I can put my discards right here, all right? Then you have a tray that you have your 4x4s here. You want to put your normal saline in here, okay? Then I want to go take out my inner cannula right here. I'm and take out my inner cannula. If it's disposable, which almost all of them are nowadays, dispose of them, get a new one. If they are not, you're gonna have to put it in here and use your pipe cleaner to clean your inner cannula, okay? I don't like to put it back here, some are stupid, don't do that. I don't like to do that, I'll just throw it in my discards here. You've also got some more pipe cleaners right here that you can use. And I'll dip it again, and I'll use my pipe cleaner again into here and clean it, okay? Then discard of it, okay? You also have the little applicators, cotton applicators, that you can clean underneath your trach. But I usually like to get my inner cannula back in. A lot of times it's a little bit easier, you put it towards the head and give it a little twist around, okay? You want to clean those crusts, like I said, underneath there. Clean all these crusts that happen to be around your trach. Discard of this one. And don't keep reusing. If you think you need more, then get more sterile applicators and clean underneath here. Then in here, they're going to give you those soft wicks, those cut. I don't like these. I like my Alevins, but it doesn't matter if it's fine. Then I'll put it in here, and then I like to clean around my trach, clean all this all around underneath here. Okay, so it's now nice and clean. And then I will either put my Alevin underneath here, which is what I prefer. So I always like to have my Alevin out. And then I'll put my Alevin underneath here. Okay, put my Alevin underneath there. And then retie me.
Would not allow me to do a thing under there like that.
Guys, probably because Dr. Schallenberger's told them.
He
to do
did,
it.
he did.
Well, what you were saying, what he told them.
Yeah,
But you know, you can always reach out to Schallenberger. A lot of times I reach out to him for a lot of stuff, and I'm gonna reach out to him again to get more people validated for inserting trachs. So it is a shared responsibility here at Banner Gateway. And I want to impress upon you that because respiratory gets called all the time. You need to do trach care. Well, it spells out real clearly here at the policy and procedure at Banner that it's a shared responsibility at Gateway. Okay? And in some facilities you go to in Banner, it's full respiratory, but it must be done twice a day or more frequently if it's soiled. Okay? So always read your policy and be real careful because sometimes what may have been told to you may not be accurate. Sometimes, like I say, if it's too good to be true, then it usually is. So always read your policy, and they're right there online. I highly recommend don't copying them out, because if you copy them out, then it even reads down here may be out of date once printed, and so you know the way those things are. So, does anyone want to come up and do any trach? Yeah.
Can I ask a question about this in general?
Uh-huh.
So I feel like, are most people walking around with their trach uncapped? I've seen people with it capped before, correct?
Yes.
So what's the difference? What determines whether they're capped or not capped?
Well, it depends where they are along in their where they are as far as getting their trachs out, etc. So then what they can have those too, but if they also want to talk, so they have talking trachs. So they have many different types of trachs, fenestrated trachs. You have tons. It depends what they're wanting to use it for. So they'll cap them so they can talk. Because remember, your trachea is here, your larynx is here. So the air's coming out here. You can't talk because nothing's vibrating the vocal cords. So they'll cap it so they can talk.
Okay.
And they can breathe fine, but they still have to have the trach in the event that they need it.
Okay.
So there's many different type of trachs out there. It just depends what you're going to use it for.
And does the cap just prevent,
The air from coming out?
and no worry about debris or,
No.
okay.
Nope. And so they probably want them to talk, but they got to leave the trach in because they may need to use it.
Okay.
Is there a particular order in which cleaning the trach and suctioning?
No, it does not matter. I usually like to suction first and then clean it. Because a lot of times when you're up here manipulating this, they're going to start coughing all that junk up. And so you're like, oh, great, now I gotta unglove, now I gotta get, so I usually like to suction first. And even when you're messing with this trach up here, when you're cleaning it, even after you suction them, it's still gonna stimulate them to cough more. So then there's more stuff's coming out.
And when you're taking the cannula out to clean, the whole thing's still open still, so they're still able to breathe
Yes.
as you're cleaning. It's not like a rushed thing. Okay.
No, oh no, you just take this out and you still have you saw the hole. No, everything is fine. And then, they're perfectly okay.
Okay.
Cleaning that inner cannula always got me more than the actual suction.
Really?
I don't know what it was that I was like looking at it and,
Crusty,
you know, and looking
But
at
if
that
it's
and
disposable, then you don't even.
No,
It's a
you don't
weird
even
thing.
clean it for
You just
that.
take
You
it
just do it to clean it
throw it away.
around. Okay.
And I prefer the disposable ones because I don't like cleaning them.
Yeah.
I just prefer to throw them away and get a new one.
Exactly.
So, and that's pretty much most trachs, but then some of them you do have to clean. I don't know if you remember the old metal ones.
I was just thinking,
Yeah.
we used to
I
have the metal
remember the
shake
metal
ones.
ones.
Yeah, where you
Metal
actually
one?
had the metal in
Yeah.
it.
Yeah.
Those I didn't like. Those
During
things-
treatment too, we'd have to have them take it out before
I
treatment
know.
because of all that metal and it would cause more
And
reaction.
one of the things I never understood was even when they had these kind, when they were getting ready to try to wean somebody off, they would put what they called a Jackson trach in them. I don't know why.
Jackson trach.
And-
What's
But
the
they
Jackson?
were
I haven't heard that
metal.
one.
This was from
This
California.
was metal.
The-
Yeah, it was a metal
It was
trach.
a metal trach, yeah, they called it a Jackson trach.
Okay. Yeah.
That was years ago though.
Okay, y'all.
Can I keep this so we
Yeah,
can
yeah,
order
you guys
it,
want
or do you
to-
want
no,
that back
you
for
can have
your,
it.
okay,
You
thank
can
you.
have it.
Thank you, everybody.
This part and we'll